Morgan Hawkins. I am a 2021 PharmD candidate, and today I'm going to be talking to you about whether or not to bridge warfarin. Today, during this quick presentation, I just want to go over some background about warfarin and AFib, and then I'm going to summarize the current guidelines, and then I'm going to go over the bridge trial, and then we're just going to talk about what patients actually need bridging. Atrial fibrillation is an irregular and often rapid heart rate that occurs when the two upper chambers of the heart experience like a chaotic electrical signal. So it results in a fast and irregular heart rhythm. And so a heart rate in atrial fibrillation can range anywhere from 100 to 175 beats per minute. So according to the CDC, it's estimated that 12.1 million people in the U.S. will have AFib in 2030. So that's a pretty significant amount of people, and 2030 is really not that far away. And so when the heart is not pumping blood as effectively, when it's an AFib, it increases the risk of a clot, and so that clot can break off and travel to the brain and cause a stroke. And so AFib increases the risk of ischemic strokes by 4 to 5 times. And so AFib causes about 1 in 7 strokes. I just wanted to quickly touch on a couple things about warfarin. So as we know, warfarin is a vitamin K antagonist, and so it inhibits the synthesis of factors 2, 7, 9, and 10. And so it takes about 5 to 7 days to see the full therapeutic effects of warfarin because it inhibits the production of clotting factors. It doesn't actually inhibit the factors themselves that are already made. And so I created a table that gives you the half-lives of all the factors that it inhibits. So for example, factor 2's half-life is 42 to 72 hours, factor 7, 4 to 6, factor 9, 27 to 48 hours, and then factor 10 half-life is 27 to 48 hours. And so you will see the effects of warfarin last about 2 to 5 days after you discontinue it. So what actually is bridging? So bridging anticoagulation is giving a short-acting blood thinner. Typically it's a low molecular weight heparin given by sub-Q route for 10 to 12 days around the time of a patient's surgery or procedure. And so when warfarin's interrupted and the INR is out of range, bridging anticoagulation reduces the patient's risk for developing blood clots, such as a stroke. So what does that look like in a patient? So a patient with a planned surgery, warfarin's typically stopped 5 to 6 days before the surgery just to allow the sufficient time for its anticoagulant effect to wane, like I just talked about in the previous slide. And so low molecular weight heparin is typically started 3 days before surgery. That last dose is given 24 hours before surgery. They have the procedure, and then the low molecular weight heparin is resumed with warfarin, usually no earlier than 24 hours after the surgery. And that bridging is continued 4 to 6 days or until the INR is in range after the surgery. So what do the guidelines currently recommend? The guidelines aren't currently extremely clear. This table is taken from the American College of Cardiology, and I just want to touch on a couple of things. So I first want to focus on the VTE risk. If a patient has had a VTE event such as a pulmonary embolism or DVT in 3 months or less, they're at a high risk and bridging may be indicated for these patients. If it's been 3 to 12 months since the event, they're at a moderate risk. And if it's been over a year since a VTE event, they're at a low risk, and bridging may not be indicated for these patients. When Dr. Butler and I had a patient where we debated to bridge or not, we also used these time cutoffs for stroke as well. So your risk of having a stroke is highest 21 to 30 days after having a stroke. So it makes sense that you're at a higher risk for clots, and bridging should be considered with those patients. The CHADS score is also considered. Notice that it's not the CHADS VASC. The higher the CHADS score, the higher the risk, and the more bridging is indicated for patients. And so ultimately, it's up to the physician to weigh the risks and benefits. So the bridge trial came out in 2015, and before this trial, there wasn't a lot of great evidence to support or not support bridging, and so this gave a lot of good information. And so it was a randomized, double-blind, placebo-controlled trial, and what it did is it compared bridging with low molecular weight heparin. They actually used dalteparin sodium, 100 international units per kilogram, twice a day. So they compared that to just not bridging, so placebo, and they were looking for the prevention of perioperative arterial thromboembolism. And so people 18 years or older with chronic AFib or flutter who had received warfarin for over 3 months were included in this trial. And the primary outcome that they were looking at was arterial thromboembolism. So we're talking about a stroke, TIA, or systemic embolism at 30 days. And so they also had a primary safety outcome, which was major bleeding. The secondary efficacy outcome was acute myocardial infarction, DVT, pulmonary embolism, and death. And then the secondary safety outcome was minor bleeding. So what did this trial find? So they found that not bridging with a low molecular weight heparin was non-inferior to bridging in preventing arterial thromboembolism, and they found that bridging increased the risk of major bleeding by almost 3 times. There was also less minor bleeding without bridging than there was with bridging. There was also no significant difference between the groups when talking about myocardial infarction, VTE, or death. So after all this information, who actually needs bridging? So long story short, the guidelines don't really give a concrete recommendation on who needs bridging or not. However, the bridge trial has provided us a lot of great information, and we may see those guidelines change in the near future. So as a provider, you need to consider the CHA2DS2-VASc score, bleed risk, length of time in the OR. The longer that they're in the OR, the higher risk of clot. And you need to consider gender as well. Females tend to clot more easily. And patient history is a really big thing to consider as well. If you have any questions, you can email me at the Drake email listed there. And I just want to thank you for listening to my presentation to Bridge or Not to Bridge.